This video demonstrates Hirschsprung's disease. The patient was an 8-month-old with rectosigmoid Hirschsprung's disease, and a junctional colostomy had been performed at birth. Trocar situated adjacent to the junctional colostomy for the hand in colon, which, as we all know, is usually arrested at the site of the transition zone. Another feature, polar coagulating instrument for this procedure. Typically, if there was a fecaloma in the distal limb, it would perhaps be an indication to convert to an open procedure. But as you will see later on, the fecaloma created minor, though not any major inconvenience of the distal sigmoid and rectum. And you can see the section on the left side of the sigmoid and rectum, and from one side to the other. And the first blood vessel to dissecting until the bleeding point comes clearly into view, and it can then be coagulated under direct vision. So as you can see, the bleeding point is now becoming visible in the form of a small spurter, and that can be coagulated comfortably using the cautery hook. And this brings a little more of its mesentery into the working area. After it is now time to mobilize the colostomy. Now, on having finished the closure of the colostomy, and see the tip protruding. A gauze pledget on a forceps wall of the rectum being divided here. Forceps coming in, the proximal colon being fed into it, and the anastomosis is now performed between the end of the proximal normal colon and the edges of the incision in the posterior wall of the anal canal. Once the anastomosis is complete, one of the blades goes above and the other below the anastomosis to join the proximal colon and the rectum together. Stay sutures away, which allows us to place another linear cutter applied and fired, leaving a small amount of rectal stump and completing the Duhamel. The child was kept on antibiotics for 5 days post-op. He had an uneventful recovery and has been followed up for 4 months without any problems. Thank you.